couple. Okay, we are recording. I didn't make it to halfway through before I remembered to do that. All right. Father, thank you for this time that you have brought us all together. And you know what's going on in everybody's life right now. And it just feels so overwhelming at times. We just help us to take a step back, to be present, to know that you've really got the world in control, and to look to you for guidance to what you would ask our next steps to be. When we need good enough, Father, help us to accept good enough as really good enough. When we need a little rest, help us to have the courage to shut things down for a little bit and take that rest. But tonight, you've brought us here to talk about some of the things that will be challenges for people that you're going to bring into our life, and you're going to allow us to walk alongside. So guide us tonight, please, Father, and help each person to take away what you brought them here to receive. We pray together in the name of Jesus. Amen. All right. Thank you all. So week 3. Last week you were talking about, or you were looking at depressive disorders, anxiety disorders, panic disorders, some of the more common disorders that we see. And one of the things that I think it's really important for us to emphasize and emphasize and emphasize again is that when you are assessing someone, you really do want to go to the DSM and look for criteria, but we're not necessarily looking to assess. Someone could have anxiety without having an anxiety disorder. Someone could have depression without having a depressive disorder. For instance, grief is something that we often see people experiencing some level of depression during grief. And my goodness, what could be more normal for grieving? And so what we want to look at when we're assessing someone is whether or not what they're experiencing is interrupting their life, and whether or not it's the duration of it, how long has it been going on, and let's see, life impact, duration, symptoms that they're experiencing, and how long have they been experiencing those specific symptoms. And so what we're looking for is what this person experiencing normal for what is going on in their life, or what we would expect for what is going on in their life. And that may not warrant a DSM diagnosis. What we use the DSM for what we use the DSM-5 for, though, is to give us some basics of symptoms that then diagnosis informs treatment planning, always. And so we have to have, whether it's a DSM-5 diagnosis or what it is, we have to have some diagnostic information that comes out of our assessment, that then results in information that lets us know how is the best way to treat this client. What are the best interventions for them? What are the best theoretical approaches to use with them? And so, I think you can kind of see that the character structure really slides pretty seamlessly into that. because it also is, we're looking at symptoms, it's informing us. And so we layer all of these tools together to make us more effective. So I always like to say that when we're starting to go through, here comes Scott back again. Let me get him, man. When we're talking about some of these psychopathological issues, that in order to have a diagnosis of any kind of disorder, the client has to meet every single criteria in the DSM for that criteria. They can't be missing a single one and still the diagnosis be valid. And so often what we are looking at is people who have features of certain certain disorders. So they might have depressive symptoms. They might have anxiety symptoms. This week you're looking at OCD, and this is another one that people will often say, well, I have OCD. Well, no, you don't, unless you meet all of the criteria for OCD as a diagnostic criteria. What you might have is some obsessive tendencies or some compulsive behaviors. And so what we want to be looking at then is the characterological issues that might be underlying. Why this is a defense mechanism. Why does this person need it? How is it helping them? So just kind of a kickstart. This week, we're also going to be looking at suicidal ideation, assessing suicidal ideation. And as most of you are aware, we are in Suicide Prevention Month. This past week has been Suicide Prevention Week. Almost every professional organization has offered some kind of free training in working with suicidal clients or friends who might be suicidal. So I would really encourage you to take advantage of as many of those as you can. Typically, there is no charge for them. Some of them will have an after class that once the webinar is finished, you can sign up for an additional class, and some of them are really good. I took a little over a year ago a really excellent training here in Indiana for survivors, for working with survivors of suicide, someone who had a family member or a friend who had suicided. And it was really a helpful resource. So kind of look for those out there, because especially right now, there are so many of the professional organizations and professionals who are offering free webinars, workshops, that kind of thing. So keep an eye out for those kinds of things. Tonight, we're going to talk about pretty much the basics of assessing for suicide. So I do have a PowerPoint. I'm talking right through it, but but this way I get to look at your faces. I get to see you. Upcoming, this week you're going to be choosing your character or your historical figure to do your final paper on. And your final paper is a treatment plan for that person. And as we're looking at treatment plans, the key words there, or the key concept to hang on to, is last week you looked at the golden thread. And that's a critical piece of assessment and diagnosis, that you want that thread of that theme to run all the way through your assessment, your diagnosis, your treatment plan. So your assessment is going to identify symptoms that you saw in the client. It's going to have your observations about the client's mental status, and then that information is going to feed your diagnosis, or is going to lead to your diagnosis. So your what's in your assessment should have specific symptoms that relate to however you're diagnosing your client. And then that thread follows through to your treatment plan and the goals you set for working with the client. So let's say you have a client that has come in and you've had a chance to talk with them, and they're reporting that they have no appetite at all. Food doesn't taste good. They don't want to eat at all. They're skipping a number of meals. Then you're going to ask, have you noticed a weight loss as a result of that? And if possible, we want to get a potential weight loss. Concern lies in if they've lost or gained 10 pounds within a month. But they could be telling us, well, I just don't want anything to eat. We want to ask that specific question about, have you experienced any weight loss? How many times a week would you say you're being able to eat something? What kinds of things are you being able to eat when you are able to eat? So we're asking those specific questions because those are what's going to give us the information to take into our diagnosis. Perhaps the client says, I'm not sleeping well at all. That doesn't give us information to put in our assessment. It doesn't give us symptoms to put in our assessment. So in that case, if the client's not telling us what's happening, we're going to be coming back to them and we're going to be asking the questions about, well, can you tell me about your sleep pattern? About what time are you going to bed? Are you waking up are you going to sleep and then waking up in the night? Or are you having difficulty going to sleep? And so again, those specifics are going to be what informs. There's other things, of course, that we would ask, but I'm kind of trying to do this briefly. So when I come to my assessment, then what my assessment is going to say is, client is a 35-year-old female experiencing, reporting loss of appetite, and then I'm going to put eating one meal every other day, difficulty sleeping, reporting falling asleep and waking up multiple times during the night. So then when I come down, and there would be other things. It might be that okay, I find out that my client has her spouse has recently said he wants a divorce. So then I'm going to include the stressors, immediate stressors that she's experiencing. So then when I come to my treatment plan, what are the things do you think that I'm going to address in my treatment plan?
Stressors?
Stressors, absolutely. Yeah.
Eating habits?
Eating habits, I'm going to specifically address those. sleeping habits. Those are the things that I'm going to specifically address when it comes to treatment plan. Now I'm going to discuss this with my client. So when we're talking about eating habits, for instance, I'm going to be asking her, well, I think eating is pretty important for keeping your health up. But I also understand that it's probably real difficult to eat right now. Food probably just doesn't sound good at all. So I wonder if we could come up with some things that you could and would be willing to do. Just not full meals, but something that you would be willing to try to eat maybe 2 to 3 times a day. And so we might come up with something like yogurt if she eats yogurt or likes yogurt, or we might come up with peanut butter and crackers. We might come up with an apple and peanut butter. But things that she would be willing to say, yeah, I think I could do that. When when people are grieving and everybody is trying to get them to eat, I just met with a young man this past week, his wife was my client, and she died a couple of weeks ago as a result of cancer complications. And so he and I were meeting, and we were talking about his eating habits. And when his wife was alive, they ate very healthily. And he was saying, everybody keeps telling me I have to eat, I have to eat, I have to eat. Nothing. I can't get the food down. So what we came up with for him was he agreed that he would eat half a slice of toast in the morning, just half. I said, feed the other one to the dog, do whatever you want to do. But he agreed he would eat half a slice of toast in the morning and half of a banana. Now, chances are he's going to finish off the whole banana once he gets started on it, and that's okay. But all he committed to was eating half of that banana. And we did a couple of other things. And so for the next 2 weeks, that's his goal. That's all he needs to worry about doing. So you gear the treatment plan to what the client can manage. This young man, is asking him to journal about his loss at this point, that's going to be wasted breath on my part. He may sometime get to that place. He is not there. Not there right now. But he is needing to tell the story because she deteriorated and died really quickly. She was not feeling well on Thursday morning. She and I had a session on Wednesday morning. She was not feeling well on Thursday morning. They took her into the hospital Friday morning, and by Friday night she had died. So this just came at him, all of a sudden, even though he says, I've been grieving all along. I knew this was a possibility. He said, but I was not ready for this, which of course he wasn't ready for this. Whoever is. But that golden thread, following that golden thread through that, okay, I've got a client who's exhibiting some depressive symptoms. Now, the other piece of that is I'm going to be looking for character structure. I may not have all of that at the beginning when we start, because at the beginning, I'm going to start with where the client says they need to start, what brought them in. And then I can add these other pieces in as adjuncts as they become more obvious and more helpful to the client. but I'm not particularly going to worry about that first day out of the bat about whether my client has character deficits in attachment or separation or integration or adulthood. I'm going to be starting to watch for those things, but those are probably going to come in a little bit later. But that golden thread, being able to follow it all the way through so that you're using the same words as you follow through from your assessment to your diagnosis to your treatment plan. You're using some of the same terms, and as much as possible, you're using clinical terms. For diagnosis and treatment class, I have a kind of a cheat sheet that I give students of some clinical terms. I'll post that for you this week in the instructors spot on Blackboard, because it could be, it might be helpful to you to see how sometimes we phrase things in clinical documents. Now, always there is the issue of, but what if I'm working with a third party payer? And a third party payer, a third party payer is going to require a DSM-5 diagnosis. Now, you know, the nice thing or the good thing about DSM-5 is we have a lot more leeway to give provisional diagnoses than we've had in previous diagnostic manuals. But just be aware that if you are working with third-party payment, you are going to need to have a DSM diagnosis, and that DSM diagnosis needs to be the category or the name of the disorder that you're prescribing, and then in parentheses the code. And there are two codes in the DSM. There's one immediately following the diagnosis. So for instance, for obsessive compulsive disorder, the first diagnostic code is 300.3. We, as of 2 years ago, we're not really using those diagnostic codes officially anymore. There are still organizations that are using them. But a little over 2 years ago, the United States joined the rest of the world in using ICD codes. So behind in parentheses behind the DSM code, you have the ICD code right there with you. So for obsessive compulsive disorder, it's F42. And again, this is a place where when you're doing practicum, when you're doing internship, when you go to work in the field, you find out what your organization, how your organization does things, and you comply with what they're saying. This is how we do it. You don't take your own methodology into the organization and say, well, okay, you guys do it this way, but this is the way I think it should be done. That if you cannot comply with the agency's methodology, go to work someplace else. Because it just creates all kinds of nightmares. And it's not that what you think is right or good might not be right and good, but it's that an organization establishes those policies and procedures for a reason. And a big part of that reason is to protect clients, particularly in organizations that are using third-party payment or are accepting things like Medicare, Medicaid. Um, um, so, so be prepared to whatever your organization does, to be flexible and adapt to how they do things. One thing that will always be consistent is that golden thread. That will always, you can always, it doesn't matter what the style of treatment plan that you have to write is. It doesn't matter what theoretical backgrounds are coming from. That golden thread is always going to be present. And if you can follow that through your assessment, diagnosis, and treatment plan, if you can follow that golden thread through those things, then you are rarely, if ever, going to have any pushback on your documentation, on your treatment plan. And that's when you're working with third-party payers. I gotta find a different way to say that. When you're working with alternate pay resources, they are going to be looking for that golden thread, and they're going to be tracking it. They're going to be looking for specific symptoms. Did you say how the client is having trouble with eating? Did you say how the client is having trouble with sleeping? Did you say how many days work the client has missed in the past month or 2 weeks or whatever? So the more specific you can be with those things, the better better chance you have of your documentation not being challenged. So questions about all of those pieces?
I have a question on the format of the treatment plan. It shows it one way, but we're using our APA format. Does it make a big difference, or are you okay with using the APA format?
I'll tell you, Denny, this is something that we've kind of wrestled around with. What I think is important is that you are able to write a treatment plan. I'm not as concerned about APA format. Now, having said that, part of the issue with you guys writing treatment plans is bringing in peer-reviewed articles that substantiate the diagnosis that you're giving, or rule of thumb is nobody cares about your opinion. If you can't validate it, don't write it. So there is the need to incorporate that peer review information in there. I am totally okay. Now everybody's not gonna agree on this. I'm concerned about what you're able to do when you get out in the field. And if you are writing documents when you get out in the field, white papers, those kinds of things, you absolutely must adhere to APA style. When you're writing a treatment plan, you're going to have a treatment plan form or format that you're going to be following, that you're going to be asked to follow. I am totally okay with you guys establishing that treatment plan format in your document. But adding your peer reviewed, for instance, if you're gonna use I have a client who's showing obsessive compulsive features. And so I'm going to incorporate some CBT into that. Then what I'm going to do is I'm going to specify the intervention that I plan to use. And then I will, in parentheses, I would put that intervention is validated or clinically validated by such and such peer review paper, and then credit that in resources. Now, granted, when you get out in the field, you're not going to look up a peer-reviewed article for everything that you do. But what's important right now is that you are able to do that, because more and more we are getting the requirements of how is your intervention validated? What told you that this would be a good intervention to use for this this
So
particular
our
requirement?
textbook is a good source for citing.
Yes. Yeah. Yep.
Thank you.
And then I belong to an organization that does white papers and that kind of thing. There was a charge to join it initially, but I can go in and say I have a client with obsessive compulsive tendencies. I can go in and I can type obsessive compulsive, and it will give me a range of documents that I can read, research documents or peer-reviewed documents that I can read to see, okay, what is the latest that's being said about interventions with someone who has obsessive compulsions. Traditionally, it's been CBT, maybe some DBT, but is there, I want to be looking and seeing, okay, is there something more that I should be doing or something different that I should be doing? And I'll tell you, the place that I see that most often is in trauma-informed therapy. I just really have to stay on top. I'm a certified trauma therapist, and I just really have to stay on top of the peer-reviewed literature to keep track of what's the latest that's being said and discovered about working with clients, with traumatized clients. When I first started working with trauma clients, it was they need to remember every detail of their trauma, and they need to be able to tell it to someone, and we've gone from that to now it's that telling every detail of their trauma can re-traumatize them. And so we're looking at, all right, how can they be in the presence of the feelings, get a mismatching experience, and start to retrain that brain function, or those brain tracks. That we're seeing there's changes like that all the time, and it's so important that we keep up with them. Now, you also, and if you've done your research class, you probably have heard this, you want to be careful too about what you read in terms of studies. I tend to not discount, but to give less weight if a study has been sponsored by a drug company. Or if a study has been sponsored by somebody who just wrote the latest and greatest book in this area. So there are some cautions that we take into that. But there are some extremely legitimate studies as well. So, all right. Any other? Yeah, go ahead.
For last week's treatment plan, were we supposed to substantiate all of our interventions with resources? Gulp. Is it
No,
for the research paper, or is it for,
No,
yes,
because
last week and moving?
I didn't tell you to do that. And what I'm looking for from last week's treatment plan is that golden thread. You know, can I follow that through your treatment plan? That's exactly what I'm going to be looking for. And so I'm not as worried about, okay, did you document the efficacy of the interventions that you chose? But I am looking for that thread to run through. Is it consistent? Have you identified symptoms? And if anybody needs to go back and tweak anything, you're welcome to do so. I am not going to be dinging you extravagantly in your first treatment plan. These are learning activities. You're learning to do these. And they're learning experiences. So if you've got the core of it down, you're gonna get the points. And then as I'm reading through them, I'll look and I'll see, okay, where's someplace that we maybe need to spend a little bit more time talking about some of these things. That make sense? Yeah.
Mary, I also have I'm sorry, I have
you're fine.
two quick questions, I believe. The first is, again, we're going back to our homework, but there's a few times that it's mentioned, reference, like, the treatment plan has two parts. It's the I Can Start and the Townsend half.
And the Townsend part, yes.
But there's not, I don't believe that we've seen any examples of the Townsend part, either for other case studies. It's just all that we're given is like the headings of the 4 character structures and then like a sentence saying what's supposed to be in each one. And so we can certainly, do that, but it does feel a little bit like we're shooting in the dark because we haven't seen that before.
Okay. So you want an example?
Yeah, it would be helpful.
I'm sorry, Stephen, because I thought there was one in there.
Yeah, I feel like we have a template.
Yeah.
But we don't really have an
example.
example.
But there wasn't an example with the template this time.
Not that I saw. I don't know if anyone else. Okay.
I'll see that you get that, because if you're
you.
right, that would be helpful.
Yeah. And then, just in general, like I wasn't sure. Part of it is maybe we've been conditioned from our other classes, but like it is helpful to have, like a video overview each week.
Yes, and that's on me. I apologize for that. I've not been getting that up the last couple of weeks, but I will get one up for this week, and you'll have them for the following weeks.
Okay, yeah, because it is helpful, so thank you.
Yes, it is helpful, and I agree with that. So, other thoughts? Okay. I'm checking time here. I have a mindfulness exercise that I've had planned on us doing, but then I thought these were things that were important for you for us to review. So what I'm going to say about that mindfulness exercise is any type of, well, not any type, let me get my thoughts together here. When we are looking at working with any client with any kind of disorder, or even the symptomology, just helping them to do some mindfulness exercises, having some that they do with you can be really helpful to them. And this week, as we are looking at obsessive compulsive disorders, the mindfulness exercise that I had chosen was one in which we asked the client to think of something stressful, one thing, and then to think of something that they enjoy. Um, and then what we do is take the client through an exercise. First of all, we ask them to talk about the stressful thing in their life. Just tell me about that. And as you're telling me, I'd like for you to pay attention to your body, to what's happening in your body. Where are you feeling anything as you are telling me about this? And when I do this exercise with children, and I've started doing it more with adults, I give them a box. They get a box of Band-Aids, a box of animal Band-Aids or character Band-Aids or whatever. And what they do is, as they're talking, they put Band-Aids where they're feeling things in their body. I've done this now a couple of times with adults, and it's worked really well. So I'm probably going to keep doing that with them as well. So when they talk about this stressor in their lives, where do they experience it in their body? And then we take a few minutes to talk about that. And then I ask them, okay, now tell me about the thing that brings you pleasure, the thing that you enjoy. And I want you to do the same thing. I want you to pay attention to what happens to your body while you're telling me about that. And we would think, okay, when they tell you about something that they enjoy, that there would be, less negative body reaction and that kind of thing. It's surprising how often when a client starts assessing their body and they're talking about something that they enjoy, they realize that they're tensing up or they're clenching their jaw. And so we get an opportunity to talk about that as well. And then I want to bring a little bit of a mismatching experience into the activity. And I ask them, okay, so as you were telling me about your stressors and where you feel it in your body and what you enjoy and where you feel it in your body, what was it like to have me just listen and hear what you had to say? No judgment, just have somebody listen to what you have to say. And hopefully it was a pleasant experience. And so then what I'll ask them to do is an experience mirror. Okay, let's just sit with that a minute and you think about what that feels like and feel it in your body. And I wonder when you leave the office even, how long do you think you might be able to hold on to that feeling of being heard? And so, we talk about all of these interventions pretty much separately as we're going through. But in a mindfulness exercise like that, I am using attuning skills. I am using advanced attuning skills. I am using reflection. I am using experience near. I am using mismatching experience. So, all in that one intervention, we bring them alongside each other to help the client have a better experience. Again, I can post you guys there. If you go online, there are thousands of mindfulness exercises. It's a good idea to start a notebook or a resource file of mindfulness exercises. There are a couple of really good books on mindfulness exercises. I think one of them is called 101 Mindfulness Exercises, and the standard ones, the breathing exercises, then there are 10 or 12 different breathing exercises that you can take a client through. The relaxation, the progressive relaxation, a lot of those are just standard mindfulness exercises that you need to have in your toolbox. But then there are some that are geared to specific interventions as well.
Mary?
So yes, yeah, go ahead, Stephen.
Do you, I mean, especially if it's something that you have, I mean, would it be possible for you to identify 2 or 3 general ones that you feel like are just your go-tos in your toolbox and
I
share
sure
those?
can. I absolutely can.
I think that's some of what's a little hard for us is, I think conceptually we understand it and we see the value. It's the practical side that we don't get in the textbook.
Yeah. Yeah, putting some of those, this is what I do with it pieces together. Absolutely. Glad to do that.
Thank you.
And you will get more of those too as you when you get on your practicum site and your internship site. Most site supervisors are more than generous with tools and resources that you can use. But I'm happy to share a few of what I've got too. Yes.
Mary, when
Yeah,
it comes
Leah?
to practical side, sorry to interrupt. I was just wondering, one of the parts is that seem a little abstract or confusing to me are the assessments. And maybe because I'm not in the field yet, I don't fully understand that. But I imagine that assessments are based on the symptoms. And I know there's like informal assessments, formal assessments. But I guess that's the confusing part. It's like the DSM is the manual of what you do once you have those assessments. But I would imagine the information you gather is also based on what kind of assessments you use. So just like as a teacher, like I know different assessments produce different results.
Right.
And so I guess I was just wondering, like, is there like a go-to for you when you're assessing trauma versus assessing OCD? Like what assessments do you use when you're in the field? Like I think that's a part that I'm also confused about.
Okay. And again, there are a number of good assessments in the appendix to the DSM-5. But there are also trauma. I typically assess based on the client's narrative, based on their story. And, you know, I'm looking for things like duration, age span when the trauma or traumas occurred. Relationship to the perpetrator. You know, so things like that are what I'm looking for as they're telling their story. And pretty much what I'm doing is gleaning that from their narrative. If I need to ask questions, I will. But as much as possible, I try to glean it from their narrative. Now, an intake to do an assessment, then you know, that's, you want to pretty much have some kind of format in mind for that, because we always want to get current symptoms. We want to get current relationships. We want to get FOFU information, family of origin information. We want to get any medications that they're on, any previous therapy that they've had. In terms of the assessment, we're looking to observe their affect, is what their Is their mood appropriate for what they're telling me? You know,
Do you have a sample intake form that you use?
I can give you a sample intake form. I don't have one anymore that I use because it's all in my head when I sit down to work with a client. I encourage them to tell their narrative, and I'm taking the notes as I go. And as I see that there's something that I need to add to what I'm taking note wise, I'll just ask about it.
Do you record your sessions?
I do not. Clients can record sessions if they want to, and then they're responsible for what happens with those recordings. I do not record sessions because I don't want to be responsible for privacy and what might happen with those sessions. So
Thank you.
now my office partner, he does videotape sessions because he does TheraPlay with families. And so he videotapes the session with the child and the interaction between the child and the parent. And then he and the parent watch those in a separate session and review them and talk about what they're seeing and what might be helpful. So so he does do that. I do not. I've had some clients who have asked about recording sessions. If they want to, that's totally okay with me, as long as they take responsibility for it.
So that would be something that comes up in the informed consent.
Yeah.
Thank you.
All right. So the time that we have left tonight, I really want us to be able to talk a little bit about suicide. So I'm gonna bring my PowerPoint up and pull it to the last pages. This is a little video on hoarding too, which we're seeing more and more of that. I'll post the video or the PowerPoint and you'll be able to see that. Okay, so everybody always asks, do you have a suicide assessment form that you use? This is a place where I will do a formal assessment if I have a client who is expressing suicidal ideation, because this needs to be documented, and it needs to be documented carefully. What happened, what I asked the client, what their responses were, what the outcome was. So, but just, you know, some of the things that we look for in terms of, you know, a client may directly say, I'm tired of living. I'm just gonna end this. I'm just gonna end it all. That's pretty direct, and we know then that we need to pursue this. But there are other situations that may not be quite as overt, where we need to be alert and be aware. Basically, every time we meet with a client, we're assessing for suicide lethality. And so we're looking for things in terms of feelings of helplessness and hopelessness, long-term depression that has not been relieved, a preoccupation with death, a low self-esteem, that critical judge is prominent for them, and life situational problems, school, work, relationships, any of those kinds of things. We're going to be, that's going to raise our alert meter. So I'm going to come back because I want us to talk about this. You're gonna do a quiz on suicide and suicidal ideation. So tell me what you think about our responsibility to our clients.
We need to check on a regular basis to see if they are in fact depressed, or particularly ask them, are they thinking of killing themselves because using the word suicide may be taboo and they don't want to go there. So if you just ask directly, are you thinking of killing
Are you
yourself?
thinking about killing yourself? Yeah. Yeah. And so when we get into those positions, we are being very direct with what we're asking. We're still doing it with a care and with empathy, but we're being very direct about what we're asking a client. And we're not accepting hedging answers. We, are you thinking about killing yourself? That's a yes or no question. This is one of the times when it's appropriate to use a closed question. Because I want a yes or no from the client. And if the answer is yes, then I want to explore that a little bit more. So tell me what you've been thinking. And again, depending on what the client says to me, I may decide, okay, this is more than just I'm frustrated with life and I'm tired and I'm weary. And so I'm going to ask some other direct questions. What else am I going to ask?
What plan do you have?
Uh-huh. Yeah. Have you thought about how you'll do this? What are you planning to do? Okay. And so if my client says, well, I thought about running my car into a tree, I've thought about taking 9 or 10 bottles of pills, I don't think I'd do a gun because that's awful messy. Then our the client has bumped up a level in interest here, but they don't have a specific plan. What else am I going to ask if the client says, I've been saving pills since my mom died. She had a bunch of pills left over and I took them and put them in a drawer, and I've just been saving pills. I think I'd just take the pills and get a good bottle of wine and drink some good wine and just go to sleep.
When are you planning on doing this?
There we go. Yeah. Do you have a plan have you thought about when you might do this? Yeah.
Would it be appropriate at this point to begin kind of making a safety plan with the client? Setting up safe people, I don't know. I don't know how much experience everyone here has with safety plans before and all the different types of, but for us, it's usually a lot of okay, well, who are some safe people that I can talk to if I feel like I'm going to do this, I promise I'm not going to hurt myself until I try to talk to these people, stuff like that.
Yeah. Yeah. And you're right, Chris. The safety plan, though, comes after we've kind of discovered the level of lethality. Because if I've got a client who's got means and opportunity and a plan, then I'm going to be referring them to ER for an evaluation. And we're not going to talk safety plan at this point because I don't trust what they would tell me. I want somebody else's eyes assessing this and ears assessing the situation. If we back it down, then yes. If they have to go to the ER, then one of the requirements in them coming back and resuming therapy is we have to create a safety plan. If they're thinking about it, have no plan, no specific means, then yes, we can talk safety plan. My safety plan includes that they have 10 people that they will agree to try to call and meet with face to face. And they will not do anything to harm themselves until they have been able to meet with one of those 10 people face to face. It can't be a phone call. It has to be that they call the person, they say, I'm needing to talk, I'm needing some help, can we meet? And then the number 10 on that list is always me. Yeah. So, you are committing to, you're not going to harm yourself until we can get together and talk face to face. If you've gone through all 9 of your other people, then I'm here. And then making sure that they have the suicide hotline number and all of those kinds of things, the local, the closest ER to them. That's all a part of their safety plan. Activities that they will agree to engage in. That's part of the safety plan. But first of all, I have to know or I want to know that when they leave my office, they're going to be safe. And if that means a visit to the ER, then I don't have a problem with that. And then I give them a choice, we can call someone, a family member, a friend, to take you over to the ER, or I will call the police and they will escort you over there. But those are the 2 options. It's not, and I never, ever put them in my car and drive them to the ER. For a number of reasons. One, because if you're driving the car, you're not being able to pay attention to what this person in the other seat is doing, and that puts both of you in a risky situation. So what else might we want to assess in terms of suicide?
Do you have a plan in place of where you're gonna do this?
Yeah, that plan is important. Yeah. Now, let's say I have a client who has recently lost a spouse, and the client is saying, I just don't know how I'm going to go on. I don't know how I'm going to live without him or her. How am I going to address that?
Part of the grieving process?
Okay, it could well be part of the grieving process.
It'd be like the motive for them doing it. Do they have the reason or the motive?
But come back to what Scott said. I'm going to ask them directly. Are you telling me that you are thinking about killing yourself? And if they say, no, I just, I'm lonely and I don't know what I'm going to do without him or her. Then we can talk about the emotions that are affiliated with that it's normal to feel lonely when a significant other is gone. And we can begin to talk about building a new relationship with that person. You can't have the old relationship anymore. That's what you're grieving. But we can talk about memories and how do you want to remember this person? So we can give them a place to normalize the loneliness. Because a lot of times people are trying to get them to go out and do stuff and be with people and And sometimes when you're grieving, what you need is to be lonely, to just have some alone time.
So can you tell me, when you send them to the ER at this point, are they gonna feel, what would the ER people do
They will
to keep
do,
them in a safe spot?
they will assess their level of lethality again. If they think they're at risk for harming themselves or harming someone else, then they can, here in Indiana, they can do a 72-hour hold, which means that they can admit them to whatever their behavioral services unit is for 72 hours. And during that 72 hours, they're put on suicide watch.
When
Okay.
you get yourself, when you're in that type of situation with the client and they do go through that 72-hour hold, do they have any sort of, is there like a betrayal between you and them in their eyes?
Yeah.
Sometimes we have to process that and it becomes a rupture and repair situation. Yes, sometimes they're gonna come out of the 72 hours and they're gonna go to another therapist, and that's okay, as long as they continue to get help. Most of the time, our relationship is such, if it's, as I said at the beginning, it's a little riskier, but most of the time our relationship is such that that when they get a little bit of space, they realize that what I have done was to protect them. And so I'm going to say the majority of the time, and I honestly, I've not had that many people who were actively suicide to the place where I felt like, we need to get you on over to the ER. And that's pretty much the way I will say it to them. You know what, I'm worried about you. We need to get you over to the ER and have someone else evaluate you as well. So I'm wondering who you could call to come take you. And because I don't want you driving. So it's cloaked in care for them, because that's my primary concern is I want you to be safe. I forget who said that suicide is a permanent decision to a momentary situation. And most of the time, if we can get some breathing room for them, then we can again begin to build in. Okay, now what do we need to do to help you walk through this time? What's going to be most helpful for you? I don't want us to stop without also talking about, is it our responsibility? Are we responsible for our clients' lives?
Theoretically, no.
The answer to that, yes, is no. We are not. So one client that I have had in over 30 years who successfully suicided, never said a word to anybody. He just went out in his garage and got in his car and closed the garage door and turned the motor on. And his 13-year-old daughter found him when she came in from school. Never a word. far as the work that we were doing, we seemed to be making progress. He was doing some things differently in his life. Never gave any indication to his wife that he was um, planning to do this. And, you know, um, did it hurt and did I wrestle with it? Absolutely. But there was no indication at all. And we see that we've had a number of, I think every community has, but we've had a number of teenagers suicide. And you know, there's always, well, what should we have noticed? What didn't we see? And the truth is that often, at least in our communities around here, teenagers who suicide are ones who appear to be extremely successful. Their grades are high, they're involved in activities. You know, they've not given any indication to anybody. They've not been in counseling, not given any indication to anybody that they were despairing enough that they intended to take their lives. So this is a tricky situation. Yeah, Leah.
Sorry, Mary, can I ask you a question? So I work with teenagers as a teacher, and I know I'm not in the counseling world yet, but I've had a number of situations where teenagers have come and told me that they want to take their lives.
Yes.
And so I guess when it comes to teenagers in terms of like consent, like my first thing has always been to call the parents right away and get them like on the phone and like understand the information. What has made me sad and frustrated is that often the parents think their kids are just making it up and like crying for wolf and crying
Yeah,
for help.
trying to get attention.
Yeah. So I think that's been really cool to figure out. Like, I'm sure as a counselor one day you might have similar situations with parents. And so then, you know, when is that line crossed where you like force parents to take a kid to the ER or like, you know, like that, I don't know, like that's where do you just leave it in the parents' hand and be like, okay, you're now, the jurisdiction is now in your hands and you're in charge. But I was wondering that.
Well, that's one stance that we can take is, you know, this is, you're taking responsibility for your child. And so if you leave here and you don't get him or her assessed, and then they choose to take their life, then you have accepted the responsibility for that. Not for making the decision, but you've accepted responsibility for not getting your child help. In a situation like you're in, I'm sure your school has a protocol as well. And I would say that if there's a school counselor, that school counselor would need to be informed about that as well. And the principal or whoever, whatever that authority chain is, would need to be informed. And then parents contacted, because threat to self or threat to others breaks confidentiality. But just so that there is some backup for you in terms of a chain of command in the school system. It's also why I recommend if you're working in an agency, be sure that you have talked with either your supervisor or the director of the agency when you are referring someone for a suicidal evaluation. Okay.
Thanks, Mary.
Do that processing. Yeah, that's scary stuff, Leah. That and so frustrating when you talk to parents and they blow it off.
Or when my administration blows it off. Like, to be honest,
Yeah,
my school counselor is not super active and administration isn't really active. And it's really frustrating when you're like, man, I'm
Yeah.
seeing a different picture based on what some kids have gone through. That just makes me go, why isn't anyone paying attention?
Yeah.
And that's how the kid's feeling, obviously, like they're feeling that. So
yeah, that's an excellent
Anyway.
question. Okay, question for you. Do we ever discount someone who is saying that they're suicidal? Are they just trying to get attention?
Never discount it.
Never discount it. You're absolutely right, Denny. Every single time you take it seriously. And I have to tell you, this is one of my interventions that I do with people who have been assessed as a borderline personality disorder, because they will often make suicidal gestures to get attention around them, and it really is. They're not meaning to suicide, but they want to raise the alert enough that people react to what they're doing. And so that's one of the reasons that I always insist on you go to the ER, because one of the things you're going to find is borderlines do not want to go to the hospital. They, well, I'm going to take that back. Some of them like to go to the hospital. They don't like to go to the hospital on suicide watch. So if they come in and they're showing me cut wrists or whatever, then my response to that kind of thing is, okay, so what was your plan? What did you do with this? What did you do for this? Don't come in bleeding into my office, because what I'm going to tell you to do is there's a first aid kit over there in the corner, bandage it up, and I think you need to go over to the ER. I'm not a doctor. I am not a physician.
I'd hand them a mop as well.
Yeah. Sometimes I'd like to. I've only had one client that was really, well, it wasn't even my client. It was an office that I shared when I first got out of school with another guy. And we were in a church, and the secretaries did our scheduling for us. And this guy had a borderline client. She had called in wanting an appointment. The secretary said he doesn't have anything open in his schedule today. I can get you in on such and such a day and at such and such a time. So she set up the appointment with the woman. About 30, 45 minutes later, the woman comes through the door, both arms dripping blood, and a razor blade in her hand. And she said, "You think you'll see me now?" And fortunately, the receptionist had a good presence of mind. So she called EMTs. She went back like she was going to talk to the therapist. They came over to my office, and he said, "I want you to go out and talk to her, because we're not going to reward this kind of behavior." Now, I am a new therapist, people. I've not been in this business a real long time. So I went out and I talked to her until the EMTs got there. But the therapist that she was his client, he was like, we're not going to reward this kind of behavior. It's not going to happen. And so then he referred her to another therapist. He said, "I can't see you anymore. If this is what you're going to be needing to do, I can't see you anymore. This breaks our trust agreement in therapy." So there are a number of formal assessments that you can use for suicide. And I think it's a good idea to have one of those also in your toolbox. NAMI has a couple of really good ones. Let me see. I think I pulled one up. Yeah, I did. This is a suicide assessment checklist. Now, you don't necessarily go down this item by item with the client, but it kind of gives you an idea when we're judging or when we're assessing lethality. There are some things that make it, that raise the bar on it. So if they have a method in mind, you know, a firearm is typically one of the highest ones. Honestly, drug poisoning, not all that high because typically people don't take enough to really overdose on. Where we see that coming into play more often is an addict who's been in recovery and who has relapsed. And they'll have an accidental overdose because their body is not used to that level of drugs anymore. And so it shocks their body. Will often cause cardiac arrest. But most people, some people do their research and they know exactly how many pills of what kind they need to take. Most people have just been stashing things, and it takes quite a bit to. They can cause some physical damage to themselves, some damage to their bodies. But if somebody reaches them within a reasonable amount of time, usually a stomach pump takes care of a lot of that. You know, what is their relationship status? And has that changed in any way recently? Then as you're listening to them, how are you assessing their sense of worthlessness, their sense of hopelessness? Are they socially isolated? Have they experienced symptoms of depression? Are they, and this is one that that we really pay attention to, is this client someone who is impulsive, who tends to make impulsive decisions or rash decisions? If their level of hostility, their intent to die, that's the, you know, yes, I'm gonna do this and nobody's gonna stop me and I don't care what anybody says. Environmental stressors and, you know, are they talking at all in terms of the future, of a future perspective? So you add all of those together and it's going to give you a score that lets you know what the potential for lethality is. Does the client have a no suicide contract or a safety plan? More often it's what we call them. What do you think the level of risk is? And so you're going to want to have documented all of this. And then this particular assessment form checklist gives you some definitions of what you're looking for. If the client has a definite plan, if they have a method, do they have availability of the method? Is there a previous psychiatric history? Have they been making any kinds of final plans? One of the things that this talks about prior attempts, well, down here, suicide, has the client had a close friend or a relative who has committed suicide or who has attempted suicide? It's important to check that out as well. But this is one form, and I will post this one for you under my instructor's site on Facebook, on Blackboard this week. But again, there are a number of these that that just give you something to be able to, some format to be able to follow and to document in your progress notes, because if there's something that we absolutely want to do with whenever we're have a client who is indicating suicidality, is we want to document every single thing that you did step by step. You want to document and be sure that that's in your progress notes. So, questions? Our time goes so fast. All right, anything that you need me to follow up on, I've got my list here of things that you've been asking for, and I'll follow up with those and get them posted for you.
And then what's your typical grading? What's your timeline on grading typically?
I actually read through all of your discussion posts and your papers for week 1. I read through those on Saturday, and typically that would be what I would be doing on Friday and Saturday is grading those. I read through them because we had our youngest minion here on Saturday. It was a surprise. We didn't know we were going to have her. Mommy is a nurse and babysitting. Mommy works Saturday, Sunday, and Monday so that she can be home with her during the rest of the week. And babysitter fell through. So
Oh, you got to babysit. That's fun.
so we got and it's, I couldn't get anything else done with her here. So I'm planning on jumping back in on that tomorrow. My mom, we're taking her at 7:30 in the morning. She has a cancer on her face, and so we're taking her to get that taken care of, and then I should be able to come back home and work on grading.
Okay.
I typically try to get each week done before the next, right before the next week is due. But obviously I'm going to be running a little bit behind this week, but I will have week 1 and 2 graded by the end of the week.
Okay, cool.
Okay. All right. And if you have any questions about grading, let me know. I'm always happy to chat with you about them. Okay. Before we go tonight,